Hi, everyone. Welcome to the Lacked Fact Weekly Podcast, which highlights recent clinically relevant research, policy statements, and protocols that you, as a practicing lactation professional, would probably like to know about. I'm your host, Dr. Eglash. I'm a board-certified family physician and breastfeeding and lactation medicine specialist at the University of Wisconsin School of Medicine and Public Health. This podcast is written and produced by the nonprofit organization IABLE, which is the Institute for the Advancement of Breastfeeding and Lactation Education. We have no commercial funders for this podcast series. Today's Lacked Fact comes from the recently published 2025 World Health Organization Contraceptive Medical Eligibility Criteria. This guideline advises on the safety of contraceptives in the context of medical illness, age, and postpartum and breastfeeding status. The last World Health Organization medical eligibility criteria guidelines were published in 2015. The Centers for Disease Control, which I'm going to now call the CDC, also publishes medical eligibility criteria for contraception. And just like the World Health Organization, they categorize contraceptives in 4 categories, either 1, 2, 3, or 4. Contraceptives in Category 1 are considered unrestricted and can be used without concern. Category 2 contraceptives are considered safe because their benefits generally outweigh the theoretical or proven risks. However, I would emphasize that there are identified risks, which I will come back to. Both Category 1 and Category 2 are colored green on the CDC chart that summarizes their recommendations, implying that they are both fine to use during lactation. Category 3 contraceptives are considered concerning, and their risks generally outweigh the advantages, so are discouraged but not contraindicated. And Category 4 medications are considered unacceptable in terms of health risk and should not be used. Both Category 3 and Category 4 are colored red on the CDC chart to imply caution. Contraception during lactation has been a contentious topic because the published research evidence is in conflict with published case reports demonstrating decreased milk production, and in some cases, a complete lack of secretory activation among women, particularly among a few who had progesterone implants placed within the first 24 to 48 hours postpartum. There are also cases of a drop in milk production when progesterone implants are placed at 4 to 6 weeks postpartum. Nevertheless, these progesterone contraceptives are labeled green because they're either Category 1 or Category 2 lactation. So let's review the updated World Health Organization medical eligibility criteria for birth control during lactation. Let's start with the immediate postpartum period. So all estrogen-containing contraceptives, whether oral, injectable, or vaginal ring preparations, are considered Category 4 or contraindicated until 6 weeks postpartum. This is also true for non-breastfeeding women because of the risk of blood clots during the first 6 weeks after birth. They recommend that the progesterone-only contraceptives, which include the progesterone-only pill, depo-medroxyprogesterone acetate, also known as Depo-Provera, and the levonorgestrel or etonogestrel implants that are typically placed under the skin in the inner arm, are all Category 2. This means that the benefits are considered to outweigh theoretical or real risks to lactation. This is the major change from 2015 to 2025. In 2015, the injectable progesterone depo was categorized as level 3, with the perceived risks of being greater than the benefits because of the risk of insufficient milk production and the fact that it's not reversible since it can't be removed like the progesterone implants or the IUD. The World Health Organization admits that the quality of the evidence for these recommendations ranges from low to very low. IUDs are also used within the first 48 hours postpartum, and the copper IUD is considered to be Category 1, so no concern regarding lactation. The progesterone IUDs are considered Category 2, so although acceptable, they have a risk of impacting milk production. As in 2015, the World Health Organization recommends avoiding either form of IUD between 48 hours and 4 weeks postpartum because of the risk of expulsion. After 4 weeks postpartum, the progesterone and copper IUDs are considered Category 1. Let's move on to discuss birth control beyond the immediate postpartum. The World Health Organization has maintained their 2015 recommendations that combined hormonal contraceptives that contain estrogen are category 3, which should be avoided until 6 months due to the risk of dropping milk production. After 6 months, they are category 2, meaning that there's still a theoretical risk, although the benefit is considered to outweigh that risk. The progesterone contraceptives are considered category 1 after 6 weeks postpartum. This means that the progesterone-only pill, Depo-Provera, the progesterone IUD, and progesterone implants are considered to have no risk to milk production. This is a good example of where our clinical experiences diverge from these recommendations. In terms of emergency contraception, the World Health Organization identifies 3 options: combined oral contraception, levonorgestrel tablets, or ulipristal acetate. Both the combined oral contraceptive and levonorgestrel emergency contraceptive agents are considered category 1 because they're typically taken as just 2 doses, so less likely to impact lactation, particularly the combined oral contraception. Ulipristal acetate is considered category 2 because the World Health Organization recommends expressing and dumping the milk for a whole week after taking it to avoid infant exposure. However, the United States Food and Drug Administration no longer requires withholding breastfeeding after taking it because the milk levels have been shown to be low. The major update in the 2025 World Health Organization medical eligibility criteria compared to 2015 is basically switching Depo-Provera from a category 3 to category 2 immediately postpartum. The CDC, on the other hand, has always considered Depo-Provera to be a level 2 early postpartum. So now the World Health Organization is more in line with the CDC for early postpartum contraception. There are a few remaining major differences between the CDC and the World Health Organization medical eligibility criteria. So first, the CDC switches a few of the progesterones from category 2 immediately postpartum to category 1 at 21 days postpartum, whereas the World Health Organization makes this switch from category 2 to category 1 at 6 weeks. The second major difference is which is the most significant difference, is the category of combined hormonal contraception under 6 months postpartum. The CDC recommends that after 1 month postpartum, the combined hormonal contraceptives are category 2, so therefore considered reasonably safe in terms of milk production. However, the World Health Organization is more cautious, and they recommend that the combined hormonal contraceptives remain as category 3 between 6 weeks and 6 months, and then become category 2 after 6 months. So here's my opinion. We have to remember that a category 2 is not a category 1. The CDC's downloadable medical eligibility chart uses a green color, as I mentioned before, for both category 1 and 2, and a red color for category 3 and 4. The green color is a good to go signal, even though these category 2 contraceptives, such as progesterone implants and Depo, can seriously impact lactation. The same problem occurs with combined hormonal contraception after 1 month because they're considered category 2 in the United States. Again, many physicians do not understand why they are category 2 versus category 1. They just see the green color on the chart and they don't worry about risks. My suggestion is that the CDC needs to use a different color for category 2 contraceptives, such as yellow, as the international signal for caution. We need more research to understand who is most impacted by hormonal contraception during lactation. The World Health Organization recognizes that the studies on contraception during lactation do not include vulnerable populations, such as women with premature infants or women with other risk factors for low production, such as older age, insulin resistance, or gestational hypertension. And sadly, I would say that when I've talked to OBGYNs about the categorization of these contraceptives during lactation, particularly category 2, they generally had no idea that they should be counseling patients about the theoretical risks to lactation. If we're going to make significant changes to enable women and other lactating parents to have agency to balance contraception and lactation, physicians and other providers should be required to have lactation education so that they can provide evidence-based shared decision-making with their patients. Otherwise, patients are at risk for experiencing unintended loss of milk production, which unfortunately to this day is still a real phenomenon in my breastfeeding medicine practice. Hey everyone, thanks for listening. I encourage you to check out iAble at lacted.org, which is LACTED.org, to learn more about our educational projects, courses, educational handouts, videos, live conferences, and webinars. By becoming a member, you are not only supporting our free projects, but you will also receive a series of benefits which you can learn about at our website. I'll be back with another LACT fact in a few weeks.